Hello, everyone, and welcome to the Gray Couch, where we will discuss all things ABA, entrepreneurship, and lifestyle. We have a very special series that is dedicated to parents as well as parents of children with special needs. Today, I am excited to have Dr. Kevin Simon join us on the Gray Couch to discuss medication management and its pros and cons, as well as the importance of consistency. Thank you so much again, Dr. Simon, for joining us today. Can you please tell us about yourself?
So I'm Dr. Kevin Simon, board-certified psychiatrist, child and adolescent psychiatry fellow, and addiction medicine fellow at Boston Children's Hospital and Harvard Medical School. I see a broad age range from basically infant all the way through age 25, and have a practice that includes folks that have depression, anxiety, as well as a number of neurodevelopmental conditions, including autism spectrum disorder.
Thank you so much. So can you tell us what exactly does a psychiatrist do?
Yeah. So psychiatrist is someone who can, one, just like diagnose mood disorders, emotional concerns or disorders across the age spectrum. But if you're a child psychiatrist, you've done a little bit more training, specifically in that basically infancy through age about 25. But yeah, we can also, in addition to diagnosing conditions, our interventions can include therapy, much like a psychologist can do. But then also, I think the specific nuance that's different for us is that we can prescribe a variety of medications that can be helpful to any number of conditions.
Okay, so aside from, I guess, your learning or your residency track, are there any other differences as it relates from a child psychiatrist or a general psychiatrist?
Yeah, so the child psychiatrist is someone who's done adult psychiatry residency, and then they've done an additional 2 years specifically only in child and adolescent. So having that 2 additional years, you're seeing kids specifically in the medical inpatient, psychiatric inpatient, and then you have like extra dedicated time in different clinics. So for instance, I had a 4-month period where I was seeing kids in the autism clinic, which may be more than just the general psychiatry resident gets. So it's someone that has a little bit more expertise in managing kids that, you're talking about kids that are on the spectrum. So the child psychiatrist would undoubtedly have more exposure and understanding the little bit of nuances, because they'll often say, if you met one kid with autism, that's exactly what you've just only met one kid with autism. Because although we have a lot of things in public health, and epidemiologically, honestly, you meet one child, that child has a little bit of a different nuance. So the more exposure you get to kids and families that have some of these challenges, the greater it is that you're able to help those kids down the line in the future when you meet them.
Okay, so when it is that, families are coming to you, what is
Mm-hmm.
it that either like families are coming with as a concern for
Right.
their child as it relates to either behaviors or they're wanting them to do something or
Right.
focus.
Right.
So pretty much, how do parents get to you?
Yeah. So parents, I guess it depends on where am I in the hospital. So I do, sometimes I'm rotating in the emergency room. I do have a clinic, and then sometimes I'm consulting to the medical floor. So I would say parents can meet me in a variety of different ways. So the most traditional way would be, you know, they're coming in because there's some concern, and so let me be very specific. We're talking about a school-aged kid, so 5 through 9. He or she maybe isn't interacting well with peers, or has a really difficult time with like transitions. So going from outside after lunch to back to inside, or the teacher's trying to get them to transition to a different subject, and that person's like really stuck on like, I really want to finish this problem, or I really want to play with these Legos. So that could be one reason that a parent and or a teacher probably alerted the parent And so they come to see me for an evaluation. And in that evaluation, I might recognize like there's some subtle differences in how this particular child is behaving and kind of just interacting with me. Because if we're being very specific about autism, sometimes they have one of the core things is like challenges in social reciprocity, or like having fluid back and flow conversation, understanding nonverbal language. And so it may be that I figure out, I think this person may be on the spectrum, and we might, refer them for like true, like autism spectrum testing.
Mhm.
So one of the ones that I'm more familiar with is the ADOS, or the Autistic Diagnostic Observational Screen. So that's one variable that a patient I can meet a patient and family. Sometimes it could be much very earlier. So there's times where, I'm working with like the EIS, or early intervention services, and we have, maybe like a toddler, are they talking, at the rate that other kids are supposed to be talking, or are they communicating? So there can be, again, early intervention classically is 0 to 3. So I meet them there. Or, it could be someone who has a diagnosis already, yet the management that they've been getting has maybe not been helpful, and then I end up seeing them in the emergency room because there was like overstimulation, and now they're suggesting things like I want to hurt myself, and so I see them in that context. So it's quite a very different number of ways that I can meet a family. So those just happen to be three versions of where I can meet them.
If it is that after your evaluations or your assessment that you believe that medication would be a fit for a particular child or adolescent that you're
Mm-hmm.
working with, how long on average would you say that it takes for a medication to work?
So that's a good question. So medication, I would say it's in the compartment of our toolbox of things to help out. So we classically have something called, within psychiatry, like the biopsychosocial model, and I kind of like just reoriented just a little bit. I say social psychobio, meaning that I try to overemphasize how much like the social environment that the kid is in can predict like how they're going to do, whether you have someone who's super verbal or nonverbal. Like they need to have consistency and understanding that, oh wait, I can trust this parent or guardian that I'm with. I securely have food ready on the table. So there's a lot of like environmental stuff that I ensure is a part of my treatment plan. And then like psychologically, how is that child, see themselves? Because again, there are some kids who know, oh, I do have autism. My brain works just a little bit differently, and so I'm doing a lot of validation and positive kind of like coaching for those kids. And then if now that child requires, psychotropic medication, it really depends on what type of medication we're talking about. So um, autism tends to coexist with other conditions. So you can have autism plus depression, autism plus anxiety, autism plus ADHD, autism plus any other number of conditions that I could go down the list of. So oftentimes there's no one medication specifically for autism. What we're doing is sometimes utilizing medications for the symptoms that may present with autism. So for instance, if a child is depressed, I would then kind of go through my algorithm of, oh, do they need antidepressant? If if it's for anxiety, do they need something for anxiety? If it's for ADHD, do they need a stimulant? Or one of our third line other medications like guanfacine. So it really depends on which medications is we're targeting for the symptoms. Another thing that classically happens for some patients is pretty severe aggression and irritability, and so we do have some medications that are specifically FDA indicated for aggression and irritability. So in terms of the timeline, I give you the timeline for the different medications. So if we're talking specifically about depression, depression and antidepressants classically take about 2 to 4 weeks to begin to see a signal that the depression is kind of easing up. Um, if we're talking about anxiety, that same 2 to 4, maybe 8 week window to see anxiety go down. Now, for anxiety specifically, there are some medications that we can give that are, like we say, as needed, meaning you can take it and kind of in the 45-minute hour window, it'll decrease it just a tad bit, but those don't work over the long duration of time. Then if we're talking about stimulants for like ADHD, those actually work like that. Well, not that quickly, but they work in about 30 minutes to an hour. And then within stimulants, there's two classes: immediate release and or long acting. The long acting, those generally work about 6 to 8 hours. The immediate release are on the averages of 3 to 4 hours. And then the ones for irritability, those can work a little bit faster. So on the range of like within the hour to 2 hours, if you're talking about the ones that are for like irritability and for mood. But those you need to consistently be taking to recognize that the mood lability or the mood stability is stable over time.
Okay. Well, thank you. I definitely think in terms of, that particular question, some key takeaways are the variability depending upon the medication.
Right.
And then also that, with the medication, it's really treating the symptomology and
Right.
there is not a medication that cures autism, because I think
Right.
that sometimes that is the misconception when families maybe prescribe the medication, that they're under the impression that the medication is to address the autism, when it's really the symptomology
Right.
that could be manifested from that particular diagnosis.
Right.
So if it is that a family or a child, I should say, is a good candidate for medication,
Mm-hmm.
and right now we're just about to go into the school year,
Right.
and I know of families that may either take off the summers from medication when their child isn't in school, or
Right.
they may only give their child medication when they go to school or during the school week. So what are your thoughts, and is there any risk or benefits to taking those like medication breaks on the weekend or
Right.
medication breaks over like holidays and things like
Right.
that?
Right. Right. So it's a good question. I'm going to give you a nuanced answer here. So it depends on the class of the medication we're talking about. If we're talking specifically about stimulants, and I'll just name some stimulants, this won't be all stimulants, but Concerta is the name of a stimulant, Focalin is the name of a stimulant, Vyvanse, Adderall, Ritalin, right? There's a lot of them. Those medications can be more augmented for, okay, during school, we're going to give Johnny or Jane the medications on school days. The notion of like the weekend off or the holiday period, it really depends on if the person's talking with their psychiatrist or their pediatrician, whoever's prescribing it, about, do, can this child attend to the activities they're supposed to be attending to if you take this medication away? Because if for some reason it's the weekend and your kid's going to be going to a baseball practice, right? Like they have to be paying attention to the baseball practice. They have to be not distracted so they don't get hit if the baseball's, thrown their way. I often try to ask parents, like, tell me what's going to happen over the weekend. And do you think your kid needs attention? Your kid needs to be not distracted. Your kid needs to be able to do what they're supposed to do. So when I start to ask them what's going to happen, then they say, okay, well, we see reason why. If we're talking about the stimulant, okay, we should give this on the weekend. Now, if it's a light weekend, this weekend's a holiday weekend, right? If it happens to be you're going to the beach, you're not going to be doing too much, cognitively tasking activities, it could be reasonable to take a weekend off.
Okay.
But if you want your kid to be responding the way that they typically do Monday through Friday, it'd be reasonable to keep them on the stimulant medication on the weekend. Now, with stimulants, there's a lot of things to think about, like appetite suppression. So sometimes I understand there can be nuance to that. For the other medications, generally, we don't think about like medication holidays or weekend holidays because if you're on something like an antidepressant, or you're on a mood stabilizer, or you're on something for anxiety, generally those need to be consistently in your bloodstream
Okay.
at a normal level, where if we do have a gap of a day, 2 days,
Mhm.
it can just be very easy that that 2 days turns into a week without the medication, turns into a month without the medication. So I just generally say, to be consistent, you should take the medication daily.
Okay.
Now, different medications have something called different half-lives, meaning some medications have a long half-life, meaning if you missed one day, it'd be okay because the medication still would be in the system. But some medications have very short half-lives, meaning if you missed a day, you really need to make sure you take it the next day. So classically, depression, anxiety, mood, irritability, those are medications that we really want patients to be consistently taking and families to consistently providing those medications.
Wow. Thank you so much for that information.
Yeah.
And if it is that, let's say, a family is being consistent with, taking the medication and there's no holidays or,
hmm
weekends off, but they're still finding that medication is not working, what can
Right.
be done at that point?
Yeah, so this is where it's very important to, have what I would consider a collaborative team. Because certainly, just as being one psychiatrist, that's it, you're just one psychiatrist. You should be having a conversation with a BCBA, should be having a conversation if they have case management, should be having conversations with the school behavioral counselor.
Mhm.
So you want to try to get an assessment of what else is happening in that child's home, or what else is happening in that child's environment, the learning environment. Maybe the behaviors that are challenging are only occurring in the school. Well, then I would say, wait, is it happening in the morning or is it happening in the evening? Because I might say, oh, well, if it's happening in the morning, okay, let's think about this. What are they getting good sleep? Did they have a good breakfast? Who's in that environment with them? Are they getting teased? Are they in an appropriate learning atmosphere that caters to those that have special needs? Do they have a 504 plan? Do they have an IEP plan? Now, if the morning's doing well, and I say, okay, well, wait, the behaviors are only happening in the evening. Okay, wait, let's think about this. What medications are they on? Are they on a medication like a short-acting stimulant that would make them look beautiful in the morning, but then in the evening they're having trouble? I might say, oh, well, hey, maybe this person needs a booster dose in the afternoon. So it really, what I would say is I have to do like a lot of investigation to understand, wait, what's the antecedent, or what's the thing that's happening before the behavioral dysregulation.
Right.
um, Depends on, are they verbal or not. If they're not verbal, I got to do like a little bit of a physical exam. Okay, is it your tummy's hurting? Is it your mouth is hurting? Is it you're having a headache? If they are verbal, I can ask them those questions and they can tell me what's going on. So it really, it takes a very nuanced like person and clinician to ask those questions, and then to get the valued opinion of our collaborators to understand, okay, this may be why the patient's having some challenges at this particular time in the day. And then if we say, okay, all things are equal, nothing's really changed, we might say, okay, maybe now we should increase the dose of the medication. But it really just takes a lot of detailed conversation about when and where the challenges are happening to make the best assessment in clinical judgment.
Yeah, and I think that that is like everything that you said has been wonderful, because I think at times families may think once they get to a psychiatrist, it's
hmm
immediately that they're going to be prescribed a medication. And I love that you consider the environment and all other factors. And then once you do your thorough assessment to determine if a medication is warranted or not. So I think that that is great that, that is your approach to treatment. And speaking, again, of if a family is prescribed the medication, does that mean
hmm
that that particular child will be on medication forever?
No, so it's a great question, and parents actually ask that often. So it again, it all depends, right? So um, if you so let me say, no is the immediate answer. No, you do not need to be on medication for the rest of your life. However, with that, you may need to be on medication for an extended period of time because, again, life itself throws a lot of wrenches in there, right? So we're talking about, but if we're talking about adolescence, there are a lot of transitions that are happening. Oh, you're going to middle school now. Okay, middle school has its sets of challenges. Oh, you're going to high school, sets of challenges. Oh, you're around test period, stress and increased anxiety. So it really depends on where are you in your life, and how much skills have you developed, right? Because if undoubtedly you have a diagnosis of autism or some neurodevelopmental condition, you should not just only be seeing a psychiatrist. You should be seeing some form of therapist. You should be seeing some form of behavioral analysis person. So undoubtedly you should be at acquiring skills
Mm-hmm.
and or taking medication, and together as you mature you'll recognize, okay, I don't think I need this Lexapro anymore, or I don't think I need to take the stimulant, or you know what, I only need to take this at this particular time.
Mm-hmm.
So seeing the patients that I've seen over the course of time, um, it really depends. So we have some patients, or I have some patients that are older, that they're verbal, they graduated high school, they transition off to college, they got their college counselor, like they made sure that they set those things up. We made sure we made sure that their educational plan got
Mm-hmm.
transitioned to college, because you got to make sure that the things that were making you successful, you continue to have those activities. I meet families that don't have state services,
Mm-hmm.
right? So I happen to be in Massachusetts. You can apply for developmental disability services. So there's a lot of nuance to, do you need to be on medication, quote unquote, forever?
Yeah.
How much other wraparound services do you have, and how are you utilizing those things before I say, oh, you know what? Okay, let's go down on this medication. Because
Right.
if you have all those services and you're doing well, yeah, it's my life goal to not have people on medication. I know
Right.
I'm a psychiatrist, but the reality is, if you're not on medication, that means you're doing well.
Mhm.
But if you need it, then you need it, and that's okay.
Yeah. So I think that's the aspect of like having that full treatment team, and everyone's piece and expertise is helping to better support
Right,
that particular child or family.
right.
So if parents are thinking, I want to stop giving my child this medication, should they just stop whenever they decide to stop, or is there a process that they would have to go through?
Yes, yeah. So they definitely should include their psychiatrist. So the person who's prescribing the medication, they should definitely communicate with them, because there are some medications, when you just try to, quote unquote, abruptly discontinue the medication, that your child could have negative side effects related to just trying to stop the medication. So again, I talked about this thing called half-life. If you
Yeah.
have a short half-life, sometimes just abruptly stopping a medication, your child could have some negative consequences and not really feel great
Mhm.
off of the medication. So there are ways to, what we say is, taper medication. So how do we structurally go down over time, so that way your son or daughter has the limited risk related to withdrawal symptoms.
Okay. Okay, thank you. And
Yeah,
I'm sure, as a psychiatrist, you've probably heard of a lot of different holistic remedies or, biomedical treatments such as
right,
hyperbaric oxygen therapy, bleach therapy, recently marijuana therapy, or the
right,
gluten-free, casein-free diet, as well as
right.
all of those types of remedies or methods that are out there. So what are your thoughts on some of those things that I just named?
Yeah, so I would say, I completely understand that parents sometimes are at their wits' end and saying that, we've seen this psychiatrist, or we've seen that psychiatrist, or this practitioner. We've been on all these medications. I want to try something else, like bleach or marijuana. What I would say is, the frustration that a family and a parent may be feeling may be related to not fully having an accurate description and picture of what is going on clinically. And so I often ask parents, you know, I know you've seen, you know, 3 psychiatrists. I know we've taken these medications, but I really want to do a really deep history and understand, okay, wait a minute, you were on this medication. What was the dose that we got to?
Mhm.
Because sometimes people are under treated. So you could be prescribed the medication, but just because you're prescribed the medication doesn't mean that you're prescribed the right dose, right? So if I'm not giving you the right dose of stimulant, you're still going to have ADHD symptoms. So, you know, just as a nuance, one set of stimulant starts at 18 milligrams, can go up to 72 milligrams. If I only give you 18 and it's not touching the ADHD, you're still going to have ADHD symptoms, but you can
Mhm.
come to me and say, "Oh, we tried that." Well, did you try that the right dose?
Right.
It's just like an antibiotic. If you have an infection and I
Mhm.
give you too small of a dose, I'm not really treating the infection. So I got to make sure if I'm giving a medication, am I adequately or has a previous provider adequately dosed it to
Mhm.
target the symptoms? Now, specifically to the therapies that you mentioned, I would not recommend bleach therapy. There's been no randomized control trial advocating that, oh, we did bleach therapy for these patients that had autism, and we did, you know, traditional therapy for these patients, and those patients with bleach therapy, you know, had improvement in their behavior or targeted symptoms. With regards to cannabis, there are very few FDA indications for medical marijuana. The one within child psychiatry is a specific type of epilepsy,
Mhm.
not autism. So I don't recommend, but I am often asked, oh, what if we got this, like, you know, cannabis or marijuana oil?
Yeah.
I don't recommend you know, a marijuana oil or anything, because honestly, it can actually worsen anxiety. And there is evidence to suggest that cannabis can potentially worsen things like psychosis. And we know that kids that have that neurodevelopmental condition actually are at a greater risk for having something like a psychosis experience. So I wouldn't inherently put them in greater risk by saying, oh, hey, try this marijuana oil, which I don't know the percentage. They're not regulated, so it's very difficult for me to say you should go do this because I don't actually know what you're getting when you take it.
Mhm.
Other therapies, so like the nutritional one, you know, before making a decision to suggest, hey, I'm not going to give my kid a particular type of dye that are in, you know, drinks, or I'm
Mhm.
not going to give them gluten or casein,
Mhm.
you know, I think it would be appropriate to have a gastroenterologist like evaluation to actually, because you can test for if your son or daughter has certain allergies to certain foods. And so if your child has an allergy to a food, that makes sense.
Right.
But if your child actually does not have an allergy to a food, just removing it and augmenting how you now shop to intentionally buy gluten-free only. If the child doesn't have, like, for instance, celiac disease, they can very well tolerate gluten. So I think, again, you need to be communicating with your pediatrician and or gastroenterology specialist before suggesting, like, augmenting your diet type.
Okay. Thank you so much just for your time today, Dr. Simon. This has been really wonderful. And I am certain that, you know, the parents that will be able to access this video, you know, will have so many takeaways because a lot of the things that I asked you today are probably some of the questions that I would say not only parents have, but also maybe some practitioners that are working with these families and helping them and their children to be as successful as possible. So, with that being said, if it is that someone wants to reach you or further connect
Yeah.
with you, do you have any, you know, social media accounts or, you know, website or email?
Yeah. So in reference to social media, people can find me at DrKMSimon, so Dr. KM Simon, both on Instagram and Twitter. I do have a website, kevinsimonmd.com, so folks can find me there. But yeah, I think, you know, I appreciate you having me on the show, and hopefully that this information, you know, is helpful to families. I certainly know that it can be challenging, particularly if you're not, very nuanced and understanding of mental health conditions, or this is your first child that has a condition like autism or any other neurodevelopmental condition. So hopefully this can be very helpful to them, and they can be better informed in taking care of their kid.
Well, again, thank you so much for your time. I really appreciate you.
Yeah, no problem. Thank you.